Hi, this is Tammy McClish. Let's go ahead and take a look at upper extremity radiographic critique. Now, the first thing I want to do when I receive a requisition is I want to make sure that the requisition has the appropriate CPT code. CPT code is current procedural terminology code. So for example, if a patient was coming in for a right hand x-ray 3-view, that would be a different CPT code than a left hand 3-view x-ray. So once I determine that I have the appropriate CPT code, I then want to go ahead and match the requisition to the patient's script. The patient's script would have what's called a diagnostic code. So I would take a look at the patient's script and make sure that the 3-view right hand was also on the patient's script. And then I would also make sure that the diagnostic code was appropriate for my right hand 3-view. So for example, if the diagnostic code said shortness of breath, that would not be appropriate for a right hand x-ray, and I would go ahead and question that. But if the right hand x-ray diagnostic code said that it was for rheumatoid arthritis, then that is something that I can go ahead and start the examination. Now, once I check the right hand 3-view and I look at the CPT code and then I take a look at the diagnostic code, which is for rheumatoid arthritis, I then want to make sure that I go to my x-ray computer and I check the accession number. The accession numbers are going to be file folders specific to procedures. So I would have a file folder for a right hand 3-view. I would have a file folder for a right wrist 3-view or any other exams that are going to be under my procedure for my patient. So when I'm looking at upper extremities, I'm looking at x-raying the patient from potentially the tips of their fingers or the tip of their thumb all the way up to and including the head of their humerus. So that's what we're going to be taking a look at right now is upper extremity. Before I even bring my patient in the room, the first thing I want to do is I want to make sure that I am looking at my source to image distance. It's either going to be 72 inches or 40 inches. Now, when I am looking at 72 inches, I'm possibly going to be looking at a standing chest x-ray, or I'm possibly going to be looking at a standing lateral cervical spine. Other than that, there's really no reason that we need to take x-rays at 72 inches. So for upper extremity work, we want to take these x-rays with a source to image distance of 40 inches. Now, the way that I check that is I bring my tabletop all the way up to its highest height, and then I bring my ruler down out of my collimator. And when I first pull the ruler out, I'm going to see that it's going to be at 9 inches. The reason for that is because it's going to be 9 inches from the collimator all the way up to the x-ray tube, cathode, and anode. That's why the measuring devices start off at 9 inches. So what I would do is I would bring my ruler all the way down to the cassette, and I'm not going to put it off to the side. It's going to be straight down to the cassette, and I'm going to make sure that it's at 40 inches. After I do that, I want to make sure that I'm in the center of the image receptor. Now in this picture, we're looking at a detail cassette. Detail cassettes, we really need to make sure that the patient is going to be in the very center of that detail cassette. Now because I'm going to be x-raying a hand, I'm going to go ahead and open my collimators to an 8x10. I'm going to center to the center of the image intensifier or the image receptor. And then I'm going to go ahead and walk away and bring my patient in. I'm also going to put down my left or right marker. That way when I walk in, I make sure that everything is perfect. And of course, I'm going to make sure that my chair is off to the side so that the patient doesn't have their legs underneath the x-ray table. Now this is how I would position the chair for a left hand. And for a right hand, I would just turn the chair around in the opposite direction. The next thing I'm going to do before I even bring the patient in is I'm going to select a radiographic technique. So for all extremities or all upper extremities, we're going to make sure that our kV range is between 55 to 65 kVp. Now, if we were x-raying a small child or an infant, we could even go down to 45 kVp, but you really don't want to go any lower than that, because anything lower than that would probably be a mammogram. So in mammograms, we're going to be shooting well down into the 20 or 30 kVp range, but not for diagnostic x-ray. Then I'm going to select the small focal spot. You should use a small focal spot or a small focal filament on all extremities because you want detail, and that's our detail focal spot. There's going to be a small or large. We want to make sure we're using small focal filament. And if you look off to the side where it says MA, you'll see a little box there, and the center of the box is colored in, and that means you're on small focal filament. We always want to start off with 100 MA for all extremities. And if you do that, if you keep to the same KVP, the same focal spot, and the same MA, all I have to think about now is time in milliseconds or time in seconds, and that will vary based upon the size of the patient. Now, back in the day when we were taking x-rays and we were using cassettes, we were going to take a hand x-ray at 55 kVp, 2.5 milliamps per second. Today, digital is so awesome that we need to only go down to 1 milliamp per second for an average adult. So it's really a great thing to have digital imaging because we can use a lot less radiographic technique. And I don't know about you, but I don't like to do math. So if I just click on the MAS, it will show me my MA times my time. If I click off on the seconds, then it'll show me the time in seconds, but that's just too much math for me, so I click on MAS and it tells me my milliamps per second. Okay, so now we're ready for a patient. So, before patients come in, think about this. A patient is standing in front of you in anatomical position. If they're in front of you in anatomical position, their palms are up, their toes are forward, and their face is forward. Therefore, if you think about somebody with their hands down to the sides and their palms up, everything in the front is going to be anterior, everything in the back is going to be posterior. So for me to take an x-ray of a PA finger, I'm going to have to put the patient's palm down. The reason I put the palm down is because the palm is anterior and the dorsum or the back of the palm is going to be your posterior part. So here is a picture of a PA finger. The x-ray view is going to be PA, posterior to anterior. Now there's something called the projection. The projection on this would be AP. So it's a PA view with a AP projection. Now I'm not going to talk about that again because it's just too confusing when you start to talk about both. So I'm now going to start only talking about the view. So this is a PA finger view. As you can see, the patient is seated to the side of the x-ray table. As you can see, their palm is facing the cassette, and their forearm and their humerus are all on the x-ray table. Now, I would really want to have a right angle on that elbow to have the prettiest picture, but this one is pretty good right here. Now, you want to make sure that the hand, the forearm, and the humerus are all at the same plane. They're not elevated, they're not lowered, they're all at the same plane. Now, this is actually an x-ray cassette. If I had a digital cassette, I would have to make sure I'm in the very center of the digital cassette. But let's just pretend this is a digital cassette, and let's just pretend that we're in the very middle. Now, when I'm x-raying your index finger, which is number 2, your middle finger, which is number 3, your ring finger, which is 4, or your pinky, which is 5, this is how I'm going to take x-rays of a PA finger. The center ray is going to be at the proximal interphalangeal joint, and that's where you're seeing the star here. And when I am hanging my x-rays on my computer, or like back in the day when we used to actually hang x-rays at the hospital, we would actually want to hang the patients from the fingers down. So this is how you want to have your x-ray on your screen. You would want to make sure that it is from the finger down. And you also want to make sure that you are putting a number on top of your image, and you're also putting a right or left marker. Now, as you can see on this x-ray, the right or left marker is actually not showing, but you want to make sure that you do have a right or left marker. Now, once you take the x-ray, you can do what's called post-processing if you're allowed to do that at your facility, and you can collimate down to the area of interest. But the best way to do that is to collimate down before you even take the x-ray so that everything you need to be on the film is on the film. So I really don't have to have a lot of that second metacarpal, but since I do, that's awesome. But in post-processing, I can go ahead and I can make that happen on this picture, and that makes the radiologist happy. I also want to make sure that there is no overlap between the joint spaces and that the palm is nice and flat, and this is a very good PA finger. Now, if I am going to go from PA and I'm working my way toward lateral, the next picture I want to take is called an oblique. Now, with digital imaging, what happens is as you take your x-rays, that is the way that they're going to show up on the radiologist screen. For most situations, not all computers are generated that way, but just think about that in your head and it'll make life much easier for you. So if I was going to take an oblique of the finger, I would take that next because that's what the radiologist wants to see next. So for the second to fifth fingers, you're going to turn them based upon the digit that you are going to be x-raying. If you are taking a picture of the index finger, which is your second digit, you're going to do a medial half rotation and you're going to turn your finger slightly so that it is going into the cassette. And for the third, fourth, and fifth fingers, you're going to move them the opposite direction and you're going to do more of a lateral rotation so that it's much easier for the patient. For all of these x-rays, the center ray is going to be at the proximal interphalangeal joint. Now, the x-ray you're seeing all the way off to the right, that is a perfectly positioned index finger. Now, that is a perfectly positioned middle finger. Now, when you are placing the patient into an oblique rotation, you want to make sure that the fingers do not overlap at all. If you don't have all the metacarpal, that's okay because we don't need it. But if we do, then that's all right too. But usually if you're going to get that, you're not going to be centering in the appropriate position. So if you're cutting off the metacarpals, that is just fine. Now, if I'm taking an x-ray of a lateral finger, numbers 2 through 5, once again, I'm going to turn them whatever they need to go, depending upon the digit that I'm going to x-ray. So the second digit is going to go into a medial lateral, and then the third, fourth, and fifth digit are going to go into a lateral medial. And that is the view, lateral medial view. And you're going to center at the proximal interphalangeal joint. Now, the best thing for taking a lateral finger x-ray is to make sure that the finger is straight. I don't want the finger going down toward the cassette like in the third digit. When you look at that picture there, think about if the finger went down toward the plate. You don't want that. If you're taking an x-ray of the third finger, you're going to have a little bit of distance between the actual finger that you're x-raying and the image receptor. That's okay. There's going to be a little magnification, but that's all we can do. You just want to make sure that the finger is straight to the image receptor. Now, if I have a patient come in for a thumb x-ray, still think of the patient in anatomical position, palm up. So if I put the patient's hand with the palm up, then I have the view as an AP view. I'm going to make sure that the patient pulls the fingers out of the way. And then remember that the thumb is only going to have two bones inside of the thumb. You're going to have the proximal phalanx and the distal phalanx. There is no middle phalanx. So for the center ray on a thumb x-ray, you're going to center at the metacarpal phalangeal joint. You want to make sure the thumb is nice and straight and you don't want to have the thumb rotated. And you're going to make sure that you mark this with a number 1 because a thumb is a number 1 finger. Now when I go to take my oblique, I'm going to have the patient put their hand down. So now it becomes a PA oblique. And with the PA oblique, you're going to make sure that you're still centering at the metacarpal phalangeal joint. And you want to make sure that you put a number 1 on this x-ray. The easiest x-ray to take is going to be a lateral thumb x-ray. All you need to do is elevate the fingers and put the thumb so it's all the way on its side, and you're also going to be centering at the metacarpal phalangeal joint. Okay, for hand x-ray, I'm going to be taking a PA hand x-ray. I'm going to have the patient seated at the side of the table. Their elbow is going to be bent, and everything's going to be on the same plane. Their hand, their forearm, and their humerus, all on the same plane. My centering is going to be at the third metacarpal phalangeal joint. I'm going to make sure that I put a right or left marker. And I really want to make sure that my patients do not bring their fingers all the way out. I want to have them close but not actually touching, because if you have them very close, then they may overlap. So this is a nice PA hand x-ray. For an oblique hand, I'm not going to change anything. All I'm going to do is move my patient. In fact, I tend to say to my patient when I walk back in, let me move you, and I just turn them a little bit. If I have a hand sponge, that's great, and I am going to turn them to a 45-degree oblique, and if I can, I'm going to support them with a wedge or a block. And I'm still going to make sure that everything that's closest to the film is touching, and I want to make sure that there's good separation between all of the phalanges. And my center ray is going to be exactly the same place, third metacarpal phalangeal joint. Now in a lateral hand, there's two different types of laterals we can take. The first picture you're seeing is called a fan lateral, where the fingers are spread out. The other x-ray you're seeing is an extension lateral. We really don't take the extension lateral much these days unless you're looking for metal or something in the hand. Most often we're going to be doing the fan lateral. With the fan lateral, we're still going to be taking our x-rays at the third metacarpal phalangeal joint and make sure that the patient brings their hand out like an OK sign, and you want to be able to see between all of the phalanges. For a wrist x-ray, patient's still seated at the side of the table. Everything is still in the same plane. Have the patient make a loose fist or curl their fingers under. Now the reason that we do that is because it brings the wrist closer down to the image receptor. We are going to center right in the mid-carpal bones. And if you're touching the sides of the patients and you can feel the radial styloid and the ulnar styloid, you're just going to go a little bit above that. And then you're just going to collimate down to just above and below the carpal bones. You don't need to see all of the phalanges at all. In fact, if you have phalanges on, you haven't collimated enough. And you want to make sure the radius and ulna are straight. So the center right with this is going to be at the carpal bones. For the oblique x-ray, once again, if I had a digital cassette, I would be right in the center. And I walk in and I tell the patient, let me move you. And I just go ahead and rotate them to a 45-degree oblique. When you are doing this, make sure that you can still see the scaphoid or the navicular bone, and you're sort of rolling it so you can see it more as elongated than you did in the previous slide. For a lateral wrist x-ray, once again, I walk in the room and I say, let me move you, and I put the patient all the way on the side. Now, usually when I'm doing this, I also want to make sure that the metacarpals are on their side and the radius and ulna on their side, but I'm also centering to the mid-carpal bones. And I want to make sure I collimate down so I'm not seeing the phalanges. Now, sometimes the doctor is going to order what's called this navicular or scaphoid view, and that's called ulnar deviation. There's a couple ways you can do it. The first picture is the one that's usually the easiest. What I'm going to do in this situation is I'm going to move the chair and put the patient facing the table. I'm going to extend their hand out. I'm going to make sure that their hand is straight, and then I'm going to take and I'm going to deviate their fingers out so that they're going to be touching more toward the ulnar side. So where your thumb comes out is the radial side. The opposite bone is going to be the ulnar side. My center ray is going to be 10 to 15 degrees toward the elbow. And I'm going to collimate down to just the carpal bones. What this does is it elongates the navicular scaphoid so that we can see it much better. It's not rounded off, it's elongated. And then the second picture is a modified where that we are going to elevate the hand 20 degrees and the center ray is going to be perpendicular to the image receptor. forearm. Now, back in the day when I went to x-ray school, we had different size cassettes. We had 8 by 10s, 10 by 12s, we had 11 by 14, 7 by 17, and 14 by 17. Most people today have image receptors that are either going to be 14 by 17 or 17 by 17. So you shouldn't have a hard time getting the patient in the center of the cassette. You want to make sure they're the center in the image receptor. And what you can do is you can put a hand on their elbow like you're going to karate chop their elbow, and put a hand on their wrist like you're going to karate chop their wrist, and just bring your hands down, and you're going to intersect between your two hands, and that's where you're going to place your center ray. Your center ray is going to be in the midpoint of the forearm, and you want to make sure that everything is in the same plane. Even your humerus, make sure that your humerus comes down as far as it can so that you don't have any bend in the elbow. And this is what an AP forearm should look like. Lateral forearm, once again, we have the patient seated to the side of the table. We have their arm bent. We have the humerus, the forearm, and the wrist all at the same level. You can bisect, make sure you're in the center of the forearm, and make sure that the wrist is also lateral. AP elbow. Patient's arm is straight out and you're centered right to the mid part of the elbow. You want to make sure that their wrist, their forearm, and their humerus are all in the same plane, and that their palm is straight up. Now, if the patient comes in and they can't move their arm, their elbow is bent, then you would take the x-rays like below. You would take one where the center ray is toward the cassette, and in this part it's going to be perpendicular to the humerus, and then you would take another one where the center ray is perpendicular to the forearm. It's okay to take two. You just wouldn't take one with the elbow bent in the middle. You want to go ahead and take 2 x-rays in this case. Now for the oblique elbow, this picture shows external rotation, and this is usually the one that the radiologists are going to want you to perform. And it's a 45-degree external rotation. And when you're doing this, you're going to see that the radius and the ulna are going to be separated so you can have a better view of the radial tuberosity. Most hospitals do not take this x-ray. This is an internal rotation with the palm down. And this is also a 45-degree oblique. What will happen here is that your radius and ulna are going to cross, and you won't be able to see your radial tuberosity. And here is a lateral. Elbow is bent. Your center ray is going to be right in the middle of the elbow. And you want to make sure that the humerus, the forearm, and the wrist are all at the same plane and you are at a 90-degree angle. AP humerus. The best way to take this x-ray is with the patient standing, but if it's a trauma, you may have to do it on the tabletop. Anything that is thicker than a knee, you do not want to use a grid. But as you can see, where she's standing, this upright chamber may have a grid that can be slipped out. If you can slip the grid out, then you can keep your radiographic technique down in the 55 to 65 range. But if you're going to be taking this AP humerus in a chest chamber with a grid, then you want to go all the way up to 70 kVp and make your radiographic parameters change based upon that. You can put a karate chop on the elbow, a karate chop at the top of the humerus, and then just bisect those 2 areas, and that's where you want to center, is to the mid-humerus. You want to make sure the patient is palm up. And when you're doing that, you're going to see that the shoulder is going to turn out away from the shoulder joint. Here's some different ways you can take a lateral humerus. Now, once again, if you're at the upright, make sure you're at 40 inches. For all of these pictures, we are going to be at 40 inches. We can take one with the patient facing the image receptor, and as you can see, the elbow is lateral. We can take one with the patient's back up against the image receptor and the palm is down. Or we can take one with the patient lying on the table with their palm down. Or we can do the trans pictures where we're going across and taking a picture of the lower part of the humerus, or we're going actually through the thorax and we're taking a picture of the upper part of the humerus. Either way that you do this, you want to make sure you have both joints on the AP and, the shoulder joint and the elbow joint. Now, if you have a small child, you may have to use some tape when you are x-raying this child. Now, if you are x-raying an upper limb, then you want to make sure that their fingers are down so that they're not curled. You can use some tape to do that. And you want to go from the fingertips all the way down 17 inches. And then you just want to take another x-ray with the patient on the side, and you would bisect to the middle of the cassette and you would take everything from the fingertips down. All right, have a good day.